Moving on to issue number 9, the outpatient prescription drug formularies, AB 339 budget change proposal.
Thank you. AB 339 made a number of changes to the Knox-Keene Act with respect to the provision of prescription drug benefits. These changes include limitations on cost sharing for a monthly supply of a prescription drug and provide standardized definitions for health plan formulary tiers to prevent discriminatory benefit designs. The DMHC requests limited term resources in the amount of $733,000 for fiscal year 16-17, $700,000 for fiscal year 17-18, and $558,000 for fiscal years 18-19 and 19-20 to produce filing guidance and related materials to demonstrate that plans are not placing these drugs in high-cost tiers to discourage enrollment, and conduct on-site surveys of health plans to verify that prescriptions are not placed in the highest cost tiers within the formularies. This request also includes resources to promulgate one regulation that will specify how the monthly caps on prescription drug out-of-pocket expenditures will work in practice and what types of formularies would constitute a discriminatory benefit design.
Thank you. Anything from Finance? LEO's office. Public comment.
Tama with Health Access also sponsored the underlying legislation, and we support the BCP and also look forward for the stakeholder process to begin for implementation.
Thank you.
Linda Way with Western Center on Law and Poverty, also in support of this BCP.
Thank you. Any other public comment? Seeing none, we'll move on to issue 10, Provider Directories, SB 137 budget change proposal.
Senate Bill 137 expands on provider directory requirements by establishing clear, specific, and ongoing requirements for publishing and maintaining health plans' provider directories, including content, updating, and reporting standards. The DMHC requests 8 permanent positions and $1.4 million for fiscal year 16-17, $1.36 million for fiscal year 17-18, and $1.18 million for fiscal years 18-19 and ongoing to address the increased workload. This workload includes for our Office of Plan Licensing to determine criteria and requirements for the implementation of the provider directory process requirements and annually perform a comprehensive review of all of the submitted filings, approximately 123 plans, 74 full service, and 49 specialized plans per year. The Division of Plan Surveys will expand its scope of routine medical surveys and conduct those annual surveys, approximately 35 per year, review deficiencies, monitor corrective actions, and conduct follow-up surveys. The Office of Financial Review will perform claims reviews of all 123 plans on a 3-year cycle and perform an annual review of plan documentation with respect to any withholdings of claims payment in accordance with this law. The Office of Enforcement anticipates receiving 15 referrals per year from other DMHC programs, with 1 referral anticipated going to trial. The Office of Legal Services will need to promulgate 1 regulation package scheduled to commence in July of this year. The regulation will clarify the format and standards of the online and paper directories and updates and will address allowable practices regarding delayed payments to providers.
Thank you. Anything from Finance? LAO? Public comment.
Tama with Health Access, one of the organizational co-sponsors for SB 137. We're here to support the BCP. We do want to note that some provisions of this legislation do take effect on July 1, and then the department is required to create uniform standards under this bill by December 31st of this year. So we are a little nervous that some of the stakeholder processes have not yet been commenced, but we look forward to those meetings soon. Thanks.
Kimberly Chen with the California Pan-Ethnic Health Network, also one of the organizational co-sponsors on this measure, or on this proposal, and want to echo the comments of my colleague.
Thank you.
Linda Way with Western Center on Law and Poverty, also in support of this proposal, but do note that we do have questions regarding the cost.
Thank you.
Michelle Cabrera with SEIU California, and would like to align ourselves with the comments of our colleagues. Thank you.
Thank you. Seeing no other public comment, we'll move on to issue 11, Vision Services, AB 684 budget change proposal.
AB 684 repealed Business and Profession Code's prohibition that caused optical companies operating under a co-location business model to be in violation of California law. This bill authorized the establishment of landlord-tenant relationships between a registered dispensing optician, an optometrist, and an optical company, as long as the lease agreement includes specified conditions. The DMHC requests 2 permanent positions and $308,000 for fiscal year 16-17 and $292,000 for fiscal year 17-18 and ongoing to conduct legal research and policy analysis and perform in-depth reviews of existing plans licensed for vision services to ensure compliance, review new vision plan filings, and perform ongoing review of those vision plans.
Thank you. Anything from Finance? LEO's office? Any public comment? Seeing no additional or no public comment, we'll move on to issue 12, Coordinated Care Initiative and Ombudsman Program Spring Finance Letter.
Thank you. So the Coordinated Care Initiative, or CCI as it's often called, is a 3-year demonstration project in 8 counties to provide better health outcomes and program satisfaction for Medi-Cal beneficiaries. The DMHC plays a small but important role for this program, and through an interagency agreement with its sister state department, the Department of Healthcare Services, conducts triennial medical plan surveys and provides oversight to the CCI Ombudsman Program. Funding and limited-term position authority provided in previous years for the CCI program will expire on June 30th of this year. As such, the DMHC requests limited-term resources in the amount of $1.46 million for fiscal year 16-17 and $522,000 for fiscal year 17 and 18. To continue its CCI efforts of transitioning dual-eligible enrollees in participating counties into managed health care, as well as providing consumer assistance through the CalMedi Connect Ombudsman Program. These figures include reimbursement authority from DHCS in the amount of $1.07 million for fiscal year 16-17 and $432,000 for fiscal year 17-18.
Thank you. Anything from Finance? LAO? Public comment? Seeing no public comment, we will move on to issue 13, Health Insurance Premium Rate Review Cycle 2 Grant Reapportionment Spring Finance Letter.
Thank you. In 2011, the DMHC was awarded a 3-year federal grant in the amount of $2.2 million. The purpose of this grant was to improve our premium rate review data collection, analysis, and reporting capabilities, as well as to expand consumer access of premium filings. The Centers for Medicare and Medicaid Services, CMS, recently approved an extension of this funding through September 30th of this year. This extension will allow the department to use approximately $100,000 of these funds to contract with a consumer advocacy organization to provide public comment on filings that will become effective January 1st of 2017. These filings should be received based on the filing timeline in June and early July of this year, so the majority of the costs associated with this would be incurred in July and August of this year. And to make that possible, the DMHC requests to reappropriate unspent federal grant funds from fiscal year 13-14 to fiscal year 16-17 in order to contract with the consumer advocacy organization.
Thank you. Anything from Finance? LAO's office? Public comment?
Tam Ma with Health Access and Support.
Thank you. Seeing no additional public comment, we'd like to thank the Department of Managed Healthcare for your presentation on all of these issues. Thank you.
Okay, thanks.
We're moving on to issue 14. We have a number of issues under the Mental Health Oversight and Accountability Commission. We welcome the Executive Director of the Commission, Toby Ewing. We have also the Deputy Director, Norma Pate, and we'll hear from Finance, LEO, and public comment.
Thank
We're
you,
ready,
Mr.
sir.
Chair. Toby Ewing with the Mental Health Services Oversight and Accountability Commission. I appreciate the opportunity to be here today. So, as indicated in the analysis, the Commission, first issue, the Commission is asking to basically reappropriate unspent research dollars in our budget specific to the broader master plan, and to also reappropriate funding that was given to the Commission from the 13-14 fiscal year to work on consensus guidelines and best practice guidelines related to involuntary treatment. In some, as noted here, we've had vacancies in our research unit. We're in the process of actually filling those vacancies, and what we're asking here is not additional funding, just additional time to spend the revenues that the MHSA has produced and the legislature has authorized us to use over a longer period.
Thank you. Anything else from Commission staff? Any other presentation?
On that topic alone? Or
on issue 14?
That would be unless you'd like to know more.
Nope.
Thank you.
Thank you. Anything from Finance, LAO's office? Is there any public comment on this item? Seeing none, we'll move on to issue 15, please.
Thank you, Mr. Chair. So item 15 is, as noted here, the legislature last year expanded funding to the Commission to support what we call our stakeholder advocacy contracts. These contracts allow the state to really implement what is envisioned in the Act, which is a requirement that persons with lived experience and family members are engaged as part of the decision-making process related to mental health policies and practices. And so last year, the legislature augmented our budget by about $1 million in order to expand those contracts to organizations advocating on behalf of veterans, organizations working with transition-age youth, and organizations working to reduce disparities. Before you is a proposal to add additional funds so that the Commission could support advocacy on behalf of California's LGBTQ community. We think that's a very important group that has some particular needs, particularly around suicide and other issues where this particular population has struggled to access services, and so giving a greater voice to that population is very important.
Thank you. Anything from Finance, LAO's office? Public comment.
Good afternoon. My name is Pashi Michelson Walker. I'm the LGBTQ Program Director for NorCal Mental Health America, and I was the Director for Phase 1 of the California LGBTQ Reducing Disparities Project. For the Reducing Disparities Project, we traveled extensively throughout the state, meeting with LGBTQ stakeholders, and what we found is that there are a great number of disparities when it comes to LGBTQ mental health and well-being, and local advocacy efforts on behalf of these populations are spotty and most often non-existent. We found the top barriers to advocacy efforts were lack of resources, including lack of a statewide guiding organization. We also found that on a statewide level, LGBTQ stakeholders and advocates are often unable to be present at crucial policymaking hearings and meetings. And again, the barrier is lack of resources, especially funding. So on behalf of LGBTQ stakeholders throughout California, many of whom could not be here today, we strongly encourage you to approve this funding request. Thank you so much for your time.
Thank you for your testimony.
Thank you, Mr. Chair. Alice Kessler on behalf of Equality California, and we would second that testimony and also thank the Commission for bringing this budget proposal forward.
Thank you.
Good afternoon, Mr. Chair. Mary Adair with the County Behavioral Health Directors in support of this proposal.
Thank you.
Good afternoon again, Mr. Chair. Kieran Savage, National Alliance on Mental Illness of California. We do support this proposal, and a couple other notes. We would encourage work to bring contracts together to strengthen all of their work. I think there's a lot of overlap between the different populations that we're funding here, and I think that's important to note. Also consistent with the Mental Health Services Act, we think it's important to be funding statewide work that does reach local communities across the state, including through our county annual Mental Health Services Act plan updates and those kinds of projects. And we also continue to see a need for evaluation of our MHSA-funded programs, and we would encourage these contracts to sort of align with that and fund programs that are showing outcomes. And lastly, we really want to thank the Commission and support the move to a competitive RFP process. We think that's an important development. Thank you.
Thank you. Any other public comment? Seeing none, we'll move on to issue 16, stakeholder proposal on advocacy contracts. We welcome Mr. Ewing to continue. We welcome Rusty Seelix, a representative from Mental Health America, to join us, and we'll hear from Finance, LAO, and public comment. We are ready when you are. Welcome.
Thank you, Mr. Chairman. Rusty Seelix from Mental Health America of California. What we're asking for here is to bring all of these contracts, which were just referred to in the previous item, up to the same level. All of these groups really have to do the same thing, and their ability to be able to represent the various consumer and family member groups. You heard about the LGBT group that's being added, the veterans, transition age youth, parents of youth with mental illness, parents of adults with mental illness, and consumers themselves. All of these groups are fairly small groups, and to give them the resources so that they can provide more effective analysis and advocacy to make sure that that viewpoint is a part of all of the, not just the Commission's decision making, but Department of Health Care Services, legislature, and county decision making. These groups need to be brought to the same level, and I believe the Commission has discussed this and has concluded that there really is, it's simply a matter of history as to how widely disparate these contracts are, and not really any logic as to why some have historically gotten more money than the others. So we'd ask they all be brought up to the level of $670,000.
Thank you. Mr. Ewing, did you want to add anything?
The Commission's supportive of this proposal. As Mr. Seelix pointed out, in the discussions as the Commission moved these historic contracts from sole source contracts to competitive contracts, they asked us, is there a historic rationale to justify the level of funding that has been made available to the various contracts? And the answer to that was no, that these were historical anomalies, and that it does make sense to bring them up to a level playing field. Also want to recognize that the Commission also indicated that there are other groups out there for whom advocacy is very important, but at the moment what they supported was expansion of support for LGBTQ communities and try to raise all boats, so to speak. So very much in support of this proposal. Thank you.
Anything from Finance?
Yes. Lawana Welch, Department of Finance, and at this time we don't have a position on this proposal.
Anything from the LEO's office? Any public comment on the proposal? Thank you. We thank you all for your testimony.
Thank you, Mr. Chair.
We're moving in our agenda to issue 23. There are stakeholder proposals on Medi-Cal issues, and they range in a number of areas. The Corporation for Supportive Housing and Housing California, Planned Parenthood, Affiliates of California, California Physical Therapy Association, California Birth Center Association, and California Hospital Association. We will call panelists forward to present each one. Let's start first with Sharon Rapport from California for the Corporation for Supportive Housing.
Good afternoon, Mr. Chair. Thank you. Homeless people are expensive to Medi-Cal. We know that from years of data. And the Department of Health Care Services is planning new resources to provide services to help homeless Californians exit homelessness and remain stably housed through both the whole person care pilots and the health home program. These opportunities are exciting, innovative ways to address homelessness. But services alone are ineffective without rental assistance to make housing accessible to people experiencing homelessness. While DHCS staff have acknowledged through both the Whole Person Care Pilot and the Health Home Program that housing with services saves healthcare dollars, evidence shows people will incur increasing healthcare costs as long as they remain homeless, even when they're receiving services that are otherwise highly effective. This proposal would fund rental assistance for about 1,000 people to exit homelessness and match the funding for these housing dollars, with the Whole Person Care and Health Home Program dollars. It would then track healthcare costs saved by providing affordable housing with services and reinvest those savings toward an extension and expansion of the program. In fact, study after study over the last 25 years confirms that affordable place to live with services that help those people maintain their housing stability saves significant Medicaid money well above the cost of rental subsidies and services. A couple of examples from other states, both New York and Massachusetts have found significant cost savings by moving people into affordable housing with services. And Massachusetts has a similar program to what we're proposing that has saved over $17,000 in Medicaid costs per year per person. So I thank you for your consideration of this proposal and look forward to your questions.
Thank you. Any questions from the committee? Member Chu.
I just want to thank you for your advocacy of this proposal. As I think Mr. Thurman knows, I have a bill in this area to really help launch a pilot program to prove the very point that you're talking about. We all know that if you're homeless, you have to engage and oftentimes incur significant costs on the healthcare side. And if we could figure out how to house someone, hopefully we can minimize the longer-term healthcare costs in this area. And our bill has already been supported, I think, unanimously out of our Housing Committee as well as our Health Committee. I want to thank the Chairman for his support of this, and I very much hope that this will be part of this year's budget as we move this forward.
Thank you. Ms. Cantwell, did you have anything to add?
No comment.
Anything from Finance?
No
anything? LL's office? Public comment?
Linda Way with Western Center on Law and Poverty. We, along with Corporation for Supportive Housing, have been working with DHCS to create a new health home benefit with the expectation that this benefit will fund services in supportive housing, and we believe this proposal addresses the whole person needs of Californians experiencing homelessness.
Thank you. Good afternoon. Joe Boniwell with Housing California, co-sponsor of this initiative. It's really imperative for us to break down the silos that exist between healthcare and housing and recognizing housing as the tool that will improve access to and the quality of healthcare for California's most vulnerable Medi-Cal beneficiaries. Thank you very much.
Thank you.
Kieran Savage, National Alliance on Mental Illness, and we do know that 40% of homeless individuals, at least 40% of homeless individuals, are living with a serious mental illness. And so we do support this proposal, and we appreciate the efforts of the department to improve the delivery and coordination of care for individuals with complex medical needs, which for many individuals does include serious mental illness. So thank you.
Thank you.
Good afternoon. Mary Adair with the County Behavioral Health Directors in support of this proposal.
Thank you. Any other public comment? Thank you for the presentation. We'll move on to the next proposal, Planned Parenthood Affiliates of California. We have today Christina Romero, who is present to make the presentation.
Good afternoon, Chair and Member. Christina Romero on behalf of Planned Parenthood Affiliates of California and our over 115 health centers throughout the state. We respectfully request that you include this item in the budget to streamline the current clinic billing and reimbursement scheme for Medi-Cal drugs and supplies. Last year, the subcommittee and assembly adopted this clinic billing proposal, which was a $5.9 million augmentation, but it unfortunately wasn't included in the final conference committee budget proposal. The current billing system is overly complex and leads to numerous billing errors that require staff time for both the clinics and the state to fix. Under our proposal, clinics would simply bill and be reimbursed at the Medi-Cal rate. The good news is that the vast majority of drugs and supplies are reimbursed currently at the Medi-Cal rate, more than 80+%. So this proposal would only affect those few that fall below the Medi-Cal rate. While the department has included dispensing fees in the Medi-Cal manual, which helps clarify one of our issues, we continue to believe that a simplified billing system would benefit both community clinics and the department.
Thank you. Any questions from committee members? Did anything from the department? Any public comment on this proposal? Seeing none, we're going to leave the item open, but thank you for your presentation. We'll move on to the next item. It is the California Physical Therapy Association, and we call forward Darren White to make the presentation.
Thank you, Mr. Chairman and Assembly members. In 1978, California passed a law that allowed for, specifically for physical therapists, to go through additional certification, and then by doing so they would be able to perform EMGs, nerve conduction studies. EMGs, nerve conduction studies, are a type of diagnostic test that helps to find nerve and muscle problems. And then again in 2000, the legislature reaffirmed that, and then in 2004, DHS, as they were known at the time, introduced a trailer bill to limit EMG nerve conduction studies to being paid only to physicians who had a residency in neurology and physiatry. Now, we had met with DHS after that happened, and they said that the reasoning for doing that was there were some physicians in particular who were billing up a lot of these codes, and they were not qualified to providing the test. So their effort was to eliminate that fraud. It was not intended at that time to exclude physical therapists intentionally from being able to be paid for Medi-Cal. We again have met with DHCS this year, and they reaffirmed that. And they had said that they acknowledged that it was an inadvertent change, that they wouldn't initiate any proposals to change it, but that they would be willing to answer any questions that might be there regarding that. Physical therapists who do EMGs, nerve conduction studies, were already paid by Medicare. We're paid by all the major insurance carriers, by workers' comp. This is something well established. It's not a question of whether we're qualified to do this. It's just a matter of this law that was proposed went through as a trailer bill to the budget, which inadvertently left physical therapists out of that. And so we're looking to correct that inadvertent that error. And part of the problem that's happening right now is that a lot of physical therapists who do the EMGs nerve conduction studies actually service the rural communities. And as we've heard a lot of testimony today about the lack of medical care and access for these individuals in these areas, I can tell you personally, I was doing these tests in Colusa and had to stop doing them because we were not being paid by Medi-Cal. My colleague, he had to leave, but he was doing them in Lake County and had to stop doing them there because of Medi-Cal restrictions on being paid. And I've had another hospital, Glenn Medical Center in Willows, who had requested I do them for them, but we were not able to do them because they're primarily Medi-Cal based.
I want to see if there's any public comment, but before I want to recognize Mr. London, who's no stranger to this committee. Did you have anything that you wanted to add?
Briefly, Mr. Chairman, Carl London, on behalf of the California Physical Therapy Association, in support of Darren White. And the issue is just, he says, a very inadvertent change in law that was done through budget trailer bill. It wasn't designed originally to push out a very qualified group of providers that are certified by a licensing board. And by the way, this is not a big run-on-the-bank type issue. There are only 20 of these people in the physical therapy profession statewide who have this extra certification. They were just left out. They do this upon physician referral. Physicians are looking for answers then, trying to figure out what's going on with the nerve conduction or in the muscle. This test is done for that. They need it done. The only place it's not being reimbursed right now is in Medi-Cal, and there's no reason we should be denying the Medi-Cal population access to that service. There's no good reason for it, and I think the department's even acknowledged that it was just kind of an inadvertent oversight. We'd appreciate your support on this. Thank you very much.
Thank you, Mr. London. Thank you, Mr. White. Any committee member questions? Anything from Finance, LAO's office? Public comment.
Sue McGinty, Chair and Professor Emeritus from California State University, Sacramento, and a member of the Government Affairs Committee for the California Physical Therapy Association, here in strong support. Thank you.
I apologize, Ms. Cantwell. Did you have anything? No. Thank you. We just love having you in the committee. You know, we like you to hear all these things. Thank you again, Mr. White and Mr. London. We have a proposal from the California Hospital Association. The chair calls Barbara Glazer to come forward and to make that presentation. Sorry, please proceed.
Chairman and members, Barbara Glazer on behalf of the California Hospital Association. I am here today to request the subcommittee to consider legislation that would extend the sunset date of the hospital quality assurance fee. The current fee sunsets January 1st, 2017. We are requesting that the sunset date be extended 1 year to January 1st, 2018. The existing hospital fee is estimated to provide annually approximately $800 million in savings to the general fund, with a certain portion of the fee revenue offsetting general fund costs for providing children's health care coverage. The budget assumes that the fee sunsets January the 1st of 2017. By extending the sunset date 1 year, the budget could assume more savings to the state. The first hospital fee was put into place in 2009 and has been in place since that time. The current fee was established through SB 239 in 2013. That bill established an alignment between hospitals and the state to ensure the maximum amount of federal funds are received for hospital care for Medi-Cal patients. The state has been receiving 24% of the net increase in payments for hospital services. We would like to propose that the fee be extended just in case the ballot initiative, which CHA is sponsoring in this November's ballot, does not pass. It's important that it be extended so that we won't see a gap in the fee, and if there is a gap, there could be a possible loss of funding. Thank you for consideration of this request.
Thank you. Anything from Finance? Anything from the LEO's office?
Amber DG, Legislative Analyst Office. As we've previously stated before the subcommittee, we've recommended that the legislature extend the hospital quality assurance fee during this legislative session to ensure that the state is able to maximize the benefit to the general fund as well as to the hospital industry.
Thank you. Committee questions? I have one. I want to be clear, the committee's not taking any statement as it relates to the ballot measure, but as this has been framed and presented, is an opportunity to ensure that the state does not lose money for programs for children and others simply by pushing out the sunset date.
That's exactly right.
And so this involves money that would be lost to the state if that date should sunset.
Yes, absolutely. There would be a possible gap in the funding because we would have to come back early next year and pass legislation very quickly before the department would have the authority to start negotiations with CMS.
Could you take us through just a bit, just briefly? These are fees paid by members of the hospital association, by hospitals. They pay a fee.
By hospitals.
And then that fee becomes revenue to support programs for children in the state. Could you talk about that in particular?
That fee is used to draw down federal dollars that are used in the Medi-Cal program. Some of that is for children's health coverage, and some of that goes back to hospitals in the form of supplemental payments based on Medi-Cal patient days.
Give me an approximation of what the fee initially is, before the drawdown. The hospitals pay the fee. What is it?
Do you want me to answer? I know the answer.
Mary knows exactly.
So for
Thank you, Ms. Cantwell.
So for 15-16, the total amount that the hospitals are paying is about $4.6 billion. And then that results in a little over $8 billion in payments to hospitals. And as Ms. Glazer said, about $800 million in general fund savings to help support children's health care coverage.
Take me through it one more time.
Sure.
You said $4.6
billion is in actual fees that the hospitals pay. A little over $8 billion in payments that then go to the hospitals.
That includes the federal drawdown amount?
That's correct.
Okay. $8 billion goes to the hospitals.
To the hospitals. And a little over $800 million is to the state to support children's health care coverage in Medi-Cal.
$800 million to the state.
Yep.
Got it. Thank you, Ms. Cantwell.
Sure.
Did you have anything else that you wanted to add on?
Nope.
The proposal? Thank you. Public comment.
Thank you, Mr. Chair. Members, Fred Noah representing the private essential access community hospitals. We very much support this proposal and want to thank the subcommittee for agendizing it this afternoon. Thank you.
Catherine Austin Scott, representing the District Hospital Leadership Forum and United Hospital Association, in support. Thank you.
Thank you.
Mira Morton here on behalf of the California Children's Hospital Association, also in support.
Thank you.
Terry Thomas on behalf of the California Association of Public Hospitals and Health Systems in support of the proposal.
Thank you. Ms. Cantwell, just one more time, the total benefit, you call them savings, total benefit, as I understand it, the $800 million that comes to the state wouldn't happen if it weren't for the fees that
Correct.
that are paid and then draw down matching federal dollars.
Right. So essentially, that would be $800 million in additional general fund we would have to spend in order to maintain the programs that we have today.
And so even though the total amount that goes back after the federal drawdown to the hospitals is $8 billion, what comes to the state is $800 million to the good.
Yes.
No state money goes out to make that $800 million.
Correct.
It's all to the credit of the state.
That's correct.
Thank you. Any additional questions from the committee? Any other additional public comment? Seeing none, thank you for the presentation. I'm going to turn things over to Assemblymember Chu. Thank him for his leadership and steering of the meeting. Thank you, sir.
Why don't we now focus on the California Birthing Center proposal?
Mr. Chair, members of the committee, Fred Main on behalf of the California Birth Center Association. The Birth Center Association represents the licensed freestanding birth centers in the state. Currently, there are 34 birth centers in California, but only 3 of them accept Medi-Cal patients. Part of that issue is the challenge of licensing, but a significant part of that is the reimbursement rates that are paid by the state to the birth centers for their reimbursements for providing care. Today, we're here to request support of restoration to the birth centers of the 10% rate reduction. We think that it is a key issue of access, both for the current birth centers. There's a freestanding birth center in Orange County, a freestanding birth center in Los Angeles, and one in Santa Rosa, and that the current rates, they are at risk of not being able to provide Medi-Cal services. It's not a question, I would say, ultimately of whether or not a mother has access to maternity services, but whether or not the option of being in a non-hospital based setting is available to them. Licensed birth centers are a great option for delivery, and they are a significant savings to the state over a hospital birth. Just putting it in perspective, right now the state is paying $1,550 for a birth center delivery. That's the rate minus the 10% cut. A normal birth in a hospital can be $15,000, of which maybe $6,000 would be reimbursed in Medi-Cal, or a cesarean section up to $26,000, of which would be $7,900 potentially reimbursed. So you can see it's a significant savings already to increase the amount of births that occur in a birth center. Second, we strongly believe that more nurse midwives would practice in a birth center, increasing the number of women that could be served if there were better rates overall. So it's both a question of the current rates and those centers that are providing services, but also then a greater incentive to nurse midwives to practice in alternative birth centers and open those up. It's been shown that women that use alternative births or licensed birth centers as an alternative have far fewer admissions for cesarean sections, and then, as I pointed out, provide cost savings long term. We actually think it's a very modest cost to the state based on the figures from the alternative or the Birth Center Association. 500 births last year. If the rates had been restored to the 10% level, you'd be looking at most $250,000 to the state, cost to the state, which very modest to the state is very important to the birth centers. So for those reasons, we would request a restoration of the 10% cut. Thank you.